I'm very glad to see so many students here and our faculty members and former students who are very successful, and people from the community who are here so frequently. You're in for a real treat tonight, and the timing is exquisite. Our guest speaker, who Professor Porter has lined up, is somebody I've known for a long time. Let's just say since we were in law school together. And he is extraordinary. And for our students, there is no one better to give you a primer on healthcare reform, leading health issues, and a primer on the exquisitely exotic budget process, congressional budget process, and then how that relates to these healthcare reform issues that are so timely. And he's going to give you all the answers in just a few minutes. And he's going to chart the path for you. But he really, truly is. He's worked for many years as the senior counsel in Stafford, one of the giants. We don't have enough of those people anymore, but Henry Waxman, Representative Henry Waxman from California, who chaired the Health and Environment Subcommittee at a time when the subcommittee was actually advancing the public health and environmental issues. And he has, on some of the major health issues of our day, crises, made behind the scenes, does not often get credit for it, but made enormous contributions on major issues, including dealing with the AIDS crisis, and not just in our country, but around the world, and the need to change society's view towards smoking and tobacco and dealing with that, improving the effectiveness of federal drug and oversight of Congress over the Federal Food and Drug Administration, and continues to do that work while now being a full-time member of Georgetown Law School and on its faculty. And what a great thing for Georgetown to have as a colleague for the tremendous faculty down at Georgetown and for the students there. So we're very glad to have for a little bit of time my friend, and actually much more important for me, somebody I've looked up to and admired his enormous work and contributions for many years. So with that, I'm just going to hand it over to the organizer of tonight's shindig, Professor Karen Porter. Karen. Thank you.
Welcome to our students, welcome to our alums. This is an event that is co-sponsored by the Center for Health, Science, and Public Policy and our Office of Alumni Affairs. It's one of the first times that we're partnering to have an event like this, at least the Health Law Center with the Alumni Office, although we do work quite often together. But we really do want to reach out to the alums, welcome them back to the law school, let them know that there's many activities here that our students are interested in being engaged with alums about, and much to offer in terms of programs. So this is one of many programs the center offers. I have the privilege of having a good friend of mine, Professor Timothy Westmoreland, with us here tonight. Unlike the dean, we were not classmates, but we did do some work together. There was a time when I served on the National Commission on AIDS as a staff member, and at that time, Tim was at the House sort of doing the budget work that he's been doing for much of his career. And that was just important work, and I can't tell you how much his work there sort of helped us with the work that we were doing. He went on from there to work for the Center for Medicaid, right, for a number of years. That too is just a tremendous experience, a wealth of knowledge, and not a lot of knowledge that many people have about that very difficult safety net, right, for many of our most vulnerable members of society. I don't want to spend a long time talking today. The Dean has said quite a lot already about Professor Westmoreland. I just want to welcome you to the event and say thank you very much to Tim to come out tonight and be here with us. So I'm just going to open it up. Let me tell you just a little bit about our format. So we're going to have him speak for about a half hour or so, and then the Dean and I will have some questions that we will first start out with, and we'll open it up to the audience. When we open it up to the audience, we'd like you to be able to be heard, so I'm going to come around and ask you to use the mic. Just in terms of logistics, there is a restroom on this floor in the back, and then after the program is over, we'll be heading upstairs for a reception. With that, welcome, Tim. Thank you.
Thank you very much. There are two mics going at the same time. I don't want to start the feedback. Thank you. It's a great pleasure to be here, and I appreciate both of you inviting me to be here and to talk about what I think is a really opaque process of the federal budget and how I think that the federal budget process itself skews and distorts legislative decision-making in a way that people don't really pay much attention to, but that I think is actually quite structural. I need to begin with a couple of disclaimers. As I said I would, the views I present are my own. They should not be construed to be those of past, present, or maybe someday future employers. And also that I teach a whole semester on federal budget process, and I'm going to be doing that in half an hour this evening. So I'm necessarily going to be talking very condensed and obviously miss many things that I'm sure people are interested in. So during the Q&A period, I look forward to going to lots of topics that I may not get to during my presentation. And then the final thing I should say, which is not a disclaimer, but just sort of an invitation in some ways, is my examples, because of what I've done with my career, will necessarily be those about health and health care. But the things I have to say about budget, I think apply in lots of different areas as well. This is congressional budget process, not just health budget process. And so education policy, transportation policy, environmental policy, even criminal law at the federal level are all hemmed in some fashion by this process that I'm going to be describing that. My premise is that the budget process distorts legislative policy in all kinds of areas, even though it appears to be value neutral, and even though it appears to be agnostic about the outcome, that it's just, it appears to be just a bookkeeping measure. But it doesn't have that effect. And that this is especially important when making laws and policy about public and community health and in assisting low-income people. No one, I think, can be a good advocate in federal policymaking if they can't follow the money. But for these programs, especially for public and community health and for low-income assistance, following the money becomes extremely vital to being able to put together an effective policy. But as I say, the budget process is pretty opaque to almost everybody, so I think that I need to begin with a discussion of some of the basics about it, just as an introduction of what I would spend the first month of a semester doing to try to get through this. But I just want to make sure that the vocabulary and the concepts are familiar when I start talking about them. I've grouped these into 4 different concepts. The first, and I'll go through them more deliberately, but that there are 3 kinds of money in the federal budget, that there is a baseline of how this money flows, there are limits to how the Congress will address these different kinds of money, and that there is something called scorekeeping, which becomes the golden key to unlocking some of these programs. So let's go back to the beginning. There are 3 kinds of money. The 3 kinds are discretionary spending, mandatory spending, and tax spending. Discretionary spending is what it sounds like. It's subject to the discretion of the Congress in any one year to decide whether to fund a program or not to fund a program. It is made up of annual, at best, these days it's drips and drabs, but usually annual, and varying appropriations laws for programs and for grants. The presumption of discretionary spending is that the money won't be there unless the Congress affirmatively acts and passes a law that the president signs to provide that money. If they don't succeed in doing that, there won't be any money for discretionary programs. Virtually all grants and contracts, NIH funding, the Defense Department funding, most education money, highways, transportation, virtually all those kinds of programs are discretionary spending that the Congress decides on an annual basis how much they'll pay for. I also think in a more abstract way, and what I think it's helpful to think of is that it's budgeting by dollars. Here's $100 million. Come back and tell me how many children you could immunize with the $100 million I give you for this year. Mandatory spending, by contrast, is almost exactly the reverse of all of those things. It's a standing commitment in a statute that there will be certain goods and services provided and that the money will be there to pay for them. It's the reverse presumption. The money will be there unless the Congress acts to change the statute that promised those things. Now, they can obviously change the statute. No Congress can bind a future Congress. But if they don't change the statute, then the money will be there, so that when I hit age 65 and have enough quarters of Social Security, Medicare will pay all my hospital and physician bills unless the Congress changes that promise. But the money will be there. It is not subject to annual and varying appropriations. And in the same kind of abstract way that I asked you to think of discretionary spending as budgeting by dollars, this is budgeting by goods and services. I'm going to guarantee that all kids get free immunizations at the age of 2. Come back and tell me afterwards how much that cost. So it's budgeting by the service or the good, not budgeting by dollars in advance. Medicare, Medicaid, Social Security, veterans' disability payments, food stamps, these kinds of programs are all mandatory spending where there is a promise in the statute that the money will be there unless the Congress and the president succeed in changing it. A lot of health programs actually get money from both types. You'll be familiar with community health centers at the federal level, low-income poverty clinics. They get grants of discretionary spending to start their programs and to pay for people who don't have any insurance of any sort. But they also, if they see a Medicaid patient as a patient in the clinic, they'll get reimbursed with mandatory money for that. And in the community health center world, about 5-7 years ago, the balance flipped, and they now get more money out of the mandatory line from Medicaid than they do from the grant support for their basic operations. The third type of spending is a little more elusive and not something I'm going to spend much time on tonight, but I want you to know. It's called tax spending. Tax spending is not just a rate cut. If the Congress changes its top bracket from 39 to 38 or something like that, that's just a change in revenues. Tax spending as a concept is the federal government foregoing its normal taxes and its normal revenue if you promise to use the money for something specific. It's trying to provide an incentive for taxpayers to do something specific with their money. For bookkeeping and accounting purposes, it's about the same thing if the federal government brought the money in at a normal rate and then sent it back out again in mandatory spending. But for distributional reasons and for political reasons, certainly, it's quite different. It's always easier for Congress to cut taxes than it is to raise them and spend money. But it is also quite different that in most tax spending programs, where the government is incentivizing people to use their own money, that high-income people get a lot more benefit out of these programs than low-income people do. It's also big. Tax spending is more than $1 trillion this year. It's more than all discretionary spending combined already this year, and that's before the Congress and the President get to their new tax package. There are lots of proposals out there that people have never heard of. George W. Bush had a comprehensive long-term care nursing home insurance proposal that was to be legislation that was tax spending. But it wasn't it was tax spending so that only upper income people would get the benefit of this nursing home subsidy. So nobody took it seriously at the time. So those are the three types of spending: discretionary spending, mandatory spending, and tax spending. It is this type of flow of money that I think is causing the distortion in the way that the Congress and the federal government make their policy. The next concept there is baseline. Oops. Baseline is how much money it will cost in mandatory spending programs or taxes, but let's just focus on mandatory spending, to carry out the promises in statute if the Congress goes on total autopilot and does nothing, no new laws. And it's not the same as last year's level. If you put as much money in next year for Medicare as we have this year for Medicare, it won't be enough. The aging of the baby boomers is simple. Inflation is simple. We've got more goods and services, which is pretty complicated. When Medicare was passed, it paid for x-rays. Now it pays for CAT scans and PET scans and ion scans and all kinds of new science fiction stuff. And all of them are much more expensive than the basic Medicare package was in 1965. And then on top of that, Medicare needs to be there as a promise if something changes in the economy. So for instance, if a lot of people, well actually this would be Medicaid, if a lot of people lose their jobs and lose their health insurance, Medicaid needs to grow automatically to meet that as well. So baseline is the concept of how much money is necessary next year and the year after that and the year after that to keep the promises that are built into the statute. It's an absolutely necessary concept because if you don't have that growth in purchasing power automatically, then eventually the promise will be eroded and eventually broken. I usually, in my own law school class, tell my students to assume that when Nick and I were in law school, we created a brand new mandatory spending program for free law school. But we didn't have a concept of baseline, we just created free law school. For my students, that would now mean that they got $15,000 a year. Georgetown is now $50,000 a year. This is not going to be keeping the promise of free law school. In much the same way, if we paid for Medicare next year with the same amount of money that we paid last year, it won't be enough to purchase as many Medicare goods and services as the statute actually promises will be there. Baseline is an extremely complicated thing to model and predict. The Congressional Budget Office of the Congress is a nonpartisan advisory group within the Congress. They're congressional staff people that function as a think tank internal to the Congress. And they and the Office of Management of Budget of the White House model baseline on an ongoing basis to estimate if there will be an epidemic. There will be a recession. They make these kinds of assumptions and modeling predictions of how much the programs will cost over the coming 10 years. And that is the line of how much money will be spent. The baseline is also, it's important to say, made up of what the current law says and promises. So if the current law promises, as Medicare does, all medically necessary hospital and physician services, then when a new hospital or physician service is approved, take CAT scans or PET scans or something like that, it is automatically paid for with mandatory spending because the statute has promised that it will be automatically paid for. And then the cost of those new services or the new prescription drug or the new vaccine is automatically built into the baseline. Limits. The Congress has lashed itself to the mast and said, please, please stop us from spending again. The deficit is too big, starting in like 1980, 1981, and created over time 2 different kinds of limits that they will allow themselves to provide for new spending. There are 2 different ones, as you might imagine. If we had a hard cap on how much money there could be for mandatory spending, then we'd run into that free law school doesn't actually pay for law school kind of problem. There wouldn't be enough money to go around. But for discretionary spending, all the money that the Congress pays for goods and services, there is one single number that the Congress passes that says all discretionary spending in the entire federal government can add up to no more than this number, whether it's for transportation or defense or the NIH or FDA, whatever it may be. This is the discretionary spending cap. It creates, in Washington politics, one gigantic zero-sum game. If you want to put together a brand new childhood immunization program that's going to cost $100 million, you have to find somebody else's program to cut for $100 million. So, because it can never grow larger than that one discretionary spending cap. And I tell my students that it creates a lamb eat lamb kind of scenario here, because it's not necessarily that a good program triumphs over a bad program. It may be that a politically weak program succumbs to a politically strong program. I, for instance, have done some data on this. I don't think it's an accident that the Indian Health Service is perpetually underfunded. They are politically not strong in being able to advocate on their own behalf, and it hasn't grown in the same way that other health spending programs do. So when people are looking for new initiatives of any sort, they are competing with other programs that are already under the discretionary spending cap. Now, the Congress violates this cap every now and then, but they don't do it for the programs for the poor and the downtrodden. They do it for building a bridge, maybe in some important politician's district. They may do it for some military spending that has a lot of popularity. But for programs like childhood immunization or Indian health or community health centers, they all have to live within the discretionary spending cap and have to compete to even stay steady in their level of spending. For mandatory spending, though, as I said, you can't have a hard cap, or the purchasing power will disappear, and the program's promise in the statute will be broken. So Congress has passed something instead called pay-as-you-go, pay-go. And it's enforced within the Congress with parliamentary points of order, and it's enforced outside of the Congress with statutes that create across-the-board cuts in a lot of programs, most programs, except for a few exempt ones. So if the program proceeds on autopilot to get bigger, there are going to be more Medicare beneficiaries next year than this year, well, that happens. That's baseline. But if the Congress makes a change in the statute so that there's a change in the promise of what will be bought with this money, well, then the Congress has to find a way to pay for that at the same time. Pay as you go. So if the new program is going to cost $100 million, the Congress has to find a way of cutting mandatory spending in another area by $100 million. Or, in rare instances, they have to find enough revenues to raise taxes by $100 million so that the net effect for that year on the deficit and the debt will be zero. So they can, of course, amend statutes. They can make everybody eligible for Medicare at age 60 instead of 65. That'd be a whole lot of new spending for a lot of people who aren't currently eligible for Medicare and would add to the baseline. But to go through the pay-as-you-go limits without triggering points of order and across-the-board cuts in other programs, they'd have to find offsetting savings or increased revenues to do so. For the first year, and the snapshot for taking this estimate is a 10-year period. To make pay-go work, this is the last of the concepts, I promise, you need something called scorekeeping. You need somebody to estimate how much this new legislation is going to cost or save. It's to maintain the baseline and to keep adding what this new legislation will do. So when you hear people discussing how the Congress's new legislation is going to cost $1 billion, this is a score created by the Congressional Budget Office. Estimating can be relatively straightforward. We've got a new childhood immunization program with mandatory spending. Well, let's figure it out. What's going to be the cost of the vaccine? How many kids are eligible for it? What proportion of families are going to accept this free vaccine? So you can add up the costs and figure out how much the program will cost by doing that kind of basic multiplication. There are complicated assumptions built into that. Somebody's going to have to decide how this pharmaceutical company is going to price their vaccine once the statute goes into place. Are they going to raise the price because they know that the government has to buy it? Or are they going to lower the price because there's gigantic volume discount for purchasing this? But one way or t'other, they're estimating the price. But in addition, they'll estimate savings. If we immunize kids, There'll be fewer Medicaid kids who show up in emergency rooms. There'll be fewer Medicaid kids who show up in hospitals. So it costs money to immunize them, but we save money from Medicaid not having to pay for hospital and emergency room care. This is the scorekeeping process that is done by the Congressional Budget Office with a set of rules and precedents and assumptions of how they've worked in the past. Some of it's just plain science fiction. When Karen and I were working together, I was asked to help take part in an estimate of how much AIDS drugs were going to cost over the next 10 years. And my question back to them was, I don't know, what do you want me to assume? Do you assume we cure AIDS in the next 10 years, or do you assume we find nothing new? This is an assumption. This is not data. You've got to give me some assumptions. But in addition to that, some of these things are pretty straightforward. If you know that the vaccine is 95% effective, and you know that kids go to the hospital with earaches or with measles if they don't get immunized, well, you can crank those data and come up with a real score for what the legislation will be. So some of it is made up of assumptions and science fiction. Some of it is made up of a lot of data. But cranking out those scores is what allows scorekeeping, which in turn allows pay-as-you-go, which in turn allows the baseline to grow in mandatory spending over time. So with those basics, let me describe some ways that I think that the budget process that I've just described distorts health policy making. Let me start with an old but good one, which fortunately we overcame. Lo, these many years ago in the Reagan administration, Medicare didn't pay for any prescription drugs at all. And there was this disease called pneumococcal pneumonia, which is a really, really bad pneumonia that kills a lot of people. I mean, it just sweeps through nursing homes and old people would die. And in the mid-'80s, a new vaccine was licensed by the FDA to prevent this pneumonia. And it's a really good vaccine, and it prevents it pretty well. So my boss at the time had legislation to ask Medicare, to force Medicare to pay for providing this new pneumonia vaccine. And the estimate came back from the Reagan administration that this was going to cost billions of dollars to do. Now, it was an expensive vaccine. It cost $100 a pop, but you only had to take it once. And the physician fees for this were pretty much already paid for in Medicare. Why? And as I went through the footnotes and the spreadsheets and trying to figure out where did all of this money go, it becomes clear in the assumptions that, and in the scorekeeping that had been done, that the estimate was based on the fact that these old people who were Medicare beneficiaries would not die of pneumonia and would therefore live to collect a hip replacement or heart surgery, or live to be in a nursing home on Medicaid. And all of these other costs that would be foregone had they just gone ahead and died were now attributed to paying for the vaccine. Now, the Reagan administration withdrew this estimate and said it was a mistake. It's not a mistake. If I were the trustee of the Medicare program, I would really want to know that I had these billions of dollars of new costs coming at me because people were going to live longer. That's something a trustee needs to know. But it's a lousy way of making health policy to say, I want people to die of a preventable disease because it's cheaper if they'll go ahead and die. And consequently, we're not going to allow this legislation to go forward to pay for the pneumococcal vaccine. It actually prompted my chairman at the time to say, to the press, if this is the way we're running Medicare, why don't we have it reimbursed for bullets and get it over with? That's cheaper still. But what I'm trying to illustrate is the pay-as-you-go process coupled with the baseline, coupled with scorekeeping, leads you to some really strange health policy that health lawyers and public policy people would never in a million years come to of their own. I would give you another example of, there must be people here who, in this group, certainly in this law school, who think about lead poisoning, about low-income communities and about kids who are poisoned with lead. Medicaid pays to screen for lead poisoning, but it doesn't pay for eradicating lead from the house, for abating the apartment, getting it out of the building. I have argued for some time that Medicaid should be allowed to pay for getting it out of there so that we don't send the same kid home after screening him and treating him, sending him home to have him chew on the same windowsill again and get lead poisoning. But in trying to figure this out, and I really do think that the score could be there, that we save money over the lifetime of this child because he is not disabled. We have beautiful epidemiology data showing that kids complete high school, complete college at a higher rate if they're not lead poisoned. There are even data out there saying kids are imprisoned at a lower rate if they're not lead poisoned. I can demonstrate to you that we save money in the long run by keeping kids from being lead poisoned. But the problem is the savings that come, well, the cost of getting the lead out of an apartment, it's really expensive to abate lead in an apartment. The cost of it is right now. The savings are 20, 30 years away when you can see that these people don't end up in jail, they complete school, they go on to better careers. The scorekeeping process only looks at the first 10 years. Because that's all that the Congress looks at, and it's all actually that the economists feel like they can justify. So lots of public health interventions that you and I would think are common sense interventions, fluoridation of water, providing some of the vaccines that protect you over our long range, their savings don't show up within the first 10 years, and their costs show up right now. So the pay-as-you-go process checkmates those programs, and you can't go forward with a new statute for that unless you find new revenues to raise taxes. And I don't think I need to tell you what the atmosphere is for raising taxes in order to do some of these things at this point. So, but lots of the public health initiatives, they just don't show up with the savings within the same time period. Let me give you another example. How about if we had a universal vaccine? How about if we get word that there's about to be an avian flu epidemic? We had this discussion about 5 years ago. But we have a new vaccine. Are we going to give it to everyone and protect the whole nation? It might be a good idea that everyone get free vaccine. But vaccines are expensive. It's going to cost some money to pay for everyone, 330 million people to get it. But there will be those savings of people who don't end up in the hospital. Except savings only count if they're savings to another federal spending stream. So I can get the savings from Medicaid, people not going to the hospital. I can get savings from Medicare. But if you're in Blue Cross, or you're in Cigna, or you're in WellPoint, those savings just go out and the budget process doesn't recognize them because they're savings to the nation, but they're not savings to the federal budget. And consequently, anything that's good for the nation as a whole, we have to pay for the expenses out of federal money, but the benefits radiate out to all kinds of other places, and we don't get to count them towards pay-as-you-go, even though I can demonstrate to you that on a one-to-one basis, it probably is a savings to do it for the entire nation. It gets a little more insidious than that because you know that the natural instinct for a staff person or a politician is to say, well, I only have these many savings, let's narrow whom we immunize. Okay, now we'll only immunize some people, not everyone. We'll immunize Medicaid beneficiaries because we get the Medicaid savings, but that means that the rest of the nation is going to get flu. This doesn't sound like a great way of making public health policy either. And finally, next to last, let me give you my experience with tobacco regulation. I worked on the tobacco bill that passed about 5 years ago to regulate tobacco as a drug and to try to reduce smoking. And we'd had very delicate negotiations with the tobacco manufacturers, with the tobacco farmers, and public health experts and the liability lawyers and various people, and we finally had a compromise package that was ready to move forward. And the public health experts looked at it and said, you know, we really actually think this will work. This labeling, these restrictions, these warnings, these education, the smoking cessation treatments, these various things will lower the rate of smoking in the US. But you know what? We have an excise tax at the federal level on cigarettes. And if we actually lower the number of people who smoke, we're reducing the revenues for the federal government. And so we had this delicate compromise ready to go, and at the very last minute, the Congressional Budget Office pops up and says, you're losing $1 billion worth of revenue in the excise taxes. You can't move forward until you do pay-as-you-go for that revenue loss. Okay, nobody was expecting to come up with this. Now, public health people would look around and say immediately, well, we're going to save money because people aren't going to be smoking and they won't be getting sick. Except people don't get sick with their first cigarette. They get sick 40 years down the line with emphysema and lung cancer. So the savings don't show up within those first 10 years. The savings show up when a 15-year-old doesn't get emphysema in 40 years later. And it's probably a good thing, in fact, that the snapshot is what it is, because the other thing that you could say is cigarettes actually save Medicare money because people don't live to collect their hip replacements and their heart transplants, and they die faster. There's a fairly famous series of law review articles of people going back and forth saying that actually the cheapest thing for the federal government to do would be to give away free cigarettes in elementary schools. That would salvage the Medicare Trust Fund and the Social Security Trust Fund. It's just lousy health policy. So I thought at the time that I had one area of savings that I could turn to get the Congressional Budget Office to model and give me a score of some savings to offset this excise tax. There would be fewer low birth weight babies of pregnant women on Medicaid. Low birth weight babies cost an awful lot of money for health care. They go to neonatal intensive care units. Medicaid babies born to Medicaid moms are automatically eligible for Medicaid. So this is a stream of spending that I could predict, and a lot of low-income women smoke, or not fewer now I can say, but a significant number, a disproportionate number of smoke. So we're going to lower neonatal intensive care costs within the Medicaid program. Because pregnant women wouldn't be smoking, and when they don't smoke, they don't have as many low birth weight babies. Got the data, I can prove it to you, here it is. Except the Congressional Budget Office looks at it and says, well, right now there are a lot of pregnant Medicaid moms who smoke who have miscarriages. If they stop smoking, those miscarriages are not going to be miscarriages, they'll be low birth weight babies. So we think that the data demonstrate that the babies that would have been miscarriages will now be neonatal intensive care, so all of your savings go away. This is when I actually got quite angry and said that I did not believe that the baseline had to have a certain number of dead babies in it in order for it to be good federal policy, but that was an unprofessional thing for me to say. I recognized that they were simply looking for what the estimated effect would be on the baseline. But we did find the money elsewhere. We found the money in a retirement system for the federal employees, but leave that to the side. The most fundamental example that I'm going to close with is one that is not so much buried in spreadsheet footnotes, but has had huge legal effects. To stay within the budget limits and to meet PAYGO for the Affordable Care Act, the Congress included a raft of offsetting revenues and savings. They reduced the future of Medicare payments for hospitals because we slowed the growth rate, and that resulted in some savings in Medicare in the next 10 years. A new excise tax was created on medical devices and a social insurance surtax for Medicare on high-income individuals. So there's new revenue coming in, there's spending going down. There was even an excise tax created on tanning salons for indoor tanning purpose. Another tax was created to help do that. But when we're just about ready to finish, the Congress still needed a little bit more money to stay within the budget limits. So rather than going back and creating more new taxes, which they couldn't find at that point that were politically doable, they looked at the Medicaid matching rate for the Medicaid expansion. Now, those of you who know the Affordable Care Act know that the Medicaid expansion for the first 3 years of the ACA is paid for with 100% federal funds. It's free to the states for the first 3 years. But in order to meet the pay-as-you-go limits and the budget restraints, the Congress decided instead to lower that rate after the first 3 years and have it go down gradually from, I think, 98 to 96 to 95 to gradually go down to 90%. So that by the time they got to 10 years into the ACA, the Medicaid matching rate was no longer just free to the states. It was not, the states got 90% federal money, but they had to come up with 10% on their own. This was the payment that was required of the states in order for them to get the Medicaid expansion money. But it is that same 10% eventual cost that the Supreme Court looked at and said, look, this is coercing states into having to spend Medicaid money of their own, and coercion is prohibited under the Constitution. The federal government may not require states to undertake this expense, and consequently made the Medicaid expansion a state-by-state decision, a voluntary one, instead of a mandatory one that the states had to do for all low-income people. As a result, nationwide, we have coverage gaps where there are a lot of states, particularly states with African American low-income people, that have refused to expand the Medicaid program, and that in those states, very low-income people have no source of health insurance. It's my guess that had the Medicaid expansion been 100% federally financed forever, as it was in the first draft, that the court would not have been able to say that this was coercion, because free money is free money. And it's hard to imagine that it was coercive if the federal government was paying for it entirely. But in order to find a PAYGO offset and to make this ACA expansion fit within the budget framework of the process, we lost universal coverage. And in those states, especially the southern states, we have gaps of very low-income people who have no source of health insurance now. And I myself believe that it's entirely because of PAYGO. I don't think anybody expected this stuff. We could have done, the budget process is not an absolute barrier. We found enough money to raise tanning salon taxes and probably got it from 85 up to 90%. We wouldn't have passed the ACA if the budget process were an absolute barrier. The ACA is budget neutral. It not only met PAYGO, but eventually it actually makes money for the federal government. But we wouldn't have the prospect of repealing it right now if the money saved in the Medicaid program were enough to be able to self-finance entirely inside to it. I'm not opposed to prudent budgeting. I really do think we need to understand how much these programs are going to cost. There's a need to make sure that huge debts are financed so that my generation doesn't pass huge debts off to younger people to pay for on my behalf. But the current budget process by itself distorts our decisions in ways that are really counterintuitive, often unfair, and sometimes, think of the pneumococcal pneumonia example, just plain immoral. And I think we need to pay attention to that. Thank you.
Very informative. It strikes me that as people have been watching the repeal and replace process, we've learned a lot about the Congressional Budget Office, or at least we've heard a lot about the Congressional Budget Office and scoring and all of the things that you introduced in the talk that you just gave. Do you think that people understand it well enough to think that that's what should be determining whether the policy goes forward? I mean, in some sense, it's helped us a little bit because they have helped to knock down the efforts by really being able to point out how many people would lose insurance and how much it would cost.
I think the Congressional Budget Office has possibly the hardest job in Washington. They have to make no one happy with their estimation process. And they have to, as best they can, stay, because of what's demanded in the Budget Act, they are supposed to stay policy neutral. What I think they've done, the criticisms that I've laid here are not about the CBO itself. I think they do incredible work. The criticisms are the way that the process is so one-dimensional that the only thing we look at is how much something costs. And when you get right down to it, it costs money to keep people alive. But what I think they've done during the process of repeal and replace has been an extremely valuable cutting through the fog of people just making numbers up. And I think the views I express are my own. They should not be construed, especially with this administration and this Congress. Having somebody who won't stand by and let people just make facts up, alternative facts, has been a very useful exercise of this, of making sure that there's someone out there that the press and to some extent the public know our dispassionate views. What I'm concerned about, and maybe what I'm concerned about needs to be put aside for a little while until we get through this horrible time now. What I'm concerned about is that process itself skews things in ways that we just don't appreciate. But what it's done to make clear of this is what's going to happen if you adopt this policy, and here's our best guess dispassionately and without politics and spin has been incredibly valuable.
I have a couple of questions.
Sure.
The first question is sort of, you're the king of the universe, and you can wave a magic wand and create a new budgeting process. We have to budget. What improvements, what would your new budget process look like?
I think I wouldn't abolish the budget process that is there. I think I'd add some other dimensions to it, if you'll allow me. Oscar Wilde had an old line of a cynic is someone who knows the price of everything and the value of nothing. And I think this process makes the Congress cynical because the only thing they get on every piece of legislation is the price tag. I think in the same way that there have been honest brokers of best guesses of what the cost will be, there should be honest brokers of best guesses to the extent that there are best guesses there of what the value of some of these things would be. So for example, in what I was just describing, I think a lot about childhood immunization. I think it would be nice if public health programs had within it that the Centers for Disease Control projected how many people would live or die, how many people get sick because of this legislation. So that take, for example, the pneumonia vaccine that I gave you. Yes, you'll look down and you'll say it costs several $1 billion to the Medicare program, but then you'll also see, and 200,000 people live during that time. And so you've got a more value-based decision to say, okay, is it worth spending billions to keep these people alive or not? And at least it's not hidden in the footnotes that way. So my friends who are budget people say, oh, don't be silly. The CDC can't do those calculations. And I say, oh, don't be silly. Did you predict the recession? I mean, no, economists don't predict. I mean, I would say that the epidemiologists can predict every bit as well as the economists can of what's going to happen. And then if you spend some time in health policy, you'll find out that a lot of, I have found out, that there are a lot of other alternative measures of quality-adjusted life years and disability-adjusted life years and these kinds of things, of metrics of what helps and what hurts for giving people the life we'd all like to live. So I guess I'm not talking about getting rid of any of the budgeting process. I just think it needs to be more three-dimensional instead of one-dimensional.
And the big concept is to insert a rigorous, debatable, but rigorous evaluation of benefits in effect, and then take that in addition to cost, so you're making policy judgments on a more informed and multidimensional basis. So the other question I have that pops to mind, it's actually a request for you to do this, is that we all hear about the Congressional Budget Office and getting a score, and we're waiting for the score, and you described how important this process is. And by the way, what's implicit in what you're saying is that the CBO is legit. They're really trying. Can you give us a little more texture, especially for our students, a little more texture on how does that process really work? We hear about it, but do they get a draft bill cold and from scratch, read through it, and then start, and is there a conversation or a dialogue? How does the CBO scoring process mechanically work?
The CBO is made up of a couple of hundred various and sundry statistics, economists, epidemiologists, a few epidemiologists, people who work with numbers, quantitative types, who spend their time trying to model. And they create the baseline, and they maintain, there's a whole staff that maintains that baseline. That's what they do. But then when a piece of legislation arises, and it looks, and first of all, I should be clear, there are not nearly enough people at the CBO to do it for every piece of legislation. So there's a pecking order, there's a hierarchy that the majority staff and the minority staff for the committee that is in charge of these programs, especially the mandatory spending and revenue programs. The committee staff will take this legislation to the CBO and say, we'd like your best guess. We'd like to see where your score might be headed on this. The CBO staff people will not tolerate being lobbied. They really they don't meet with outsiders, and they don't want the committee staff trying to persuade them. That's why I say I was unprofessional with this discussion of tobacco at one point. But after they understand what the proposal is, and they may have questions along the way to say, okay, you want a new immunization program, is it going to be, and you're unclear here, how are you making the decision of which vaccines are routinely paid for or not? But they'll ask those kinds of questions back and forth. But then after that, they work with available data sets that they may have, that they'll go through the medical data. In my field, they'll go through the medical data to look to see, okay, let's see how effective this vaccine is. Let's see how many adverse events and side effects there are. Let's see how much the hospitalization is. And they'll put those data sets together and turn it into a model. And then they'll also call around to supposedly impartial experts, if there are such things as impartial experts, call around and see what kinds of unpublished data do you have on this. And go through those kinds of models to come up with their first estimate, their basic score there. And then to some extent, if it's a very high priority item that's about to move forward as legislation, repeal and replace would be one of them, the ACA itself another, that they'll do the same thing with alternative scenarios. You say, okay, if I didn't pay for 100% of Medicaid but only paid for 90% of it, how would that affect how your estimate is going to come out? And they will run some scenarios. They will deal with, if you will, rank and file members of Congress and their staff if they have time. But when legislation is moving forward to the floor, there is very rarely time for dealing with anyone other than the chair and the ranking member and and the committee staff. Is that answering your question?
That's excellent. That's terrific. And that, these are people who are very substantive.
Oh.
That take the information. There isn't maybe an initial exchange to get right what the issues are, but then they take off and they come back. But try to put some understanding about the level of magnitude of the work involved. They are getting, the process that we learned about in junior high school on how our laws are made is not exactly how it's working right now.
No.
Okay, I think that's a fair statement.
I think that's a fair statement.
And so the idea of observing, watching, following a piece of legislation as it works its way through from introduction through the committee stages and so on is not, and so on some of these major proposals, we're seeing a draft come out fresh on major issues, whether it's financial services or healthcare. So it goes to the CBO. How can they do that amount of work? How long does it take them, for example, to evaluate one of the various ACA proposal, reform or repeal proposals come through?
It's really quick, the turnaround. There's some basics there.
Well, it depends on, I think, how much is already built into the baseline, that they feel like they have an understanding of the data that are necessary to make little time. If you wanted to change, make it up, do you want to change the premium cost from $100 a person in of cost sharing to 150? Do they have data already for those kinds of things? Can they already have the spreadsheet set up? But I guess I want to answer with an anecdote instead, if I may, which is
Sure.
when in the mid-2000s, when Medicare prescription drug benefits, Medicare Part D, was first being considered, and it was a George W. Bush proposal, and was ultimately enacted, and that's what Medicare prescription drug coverage is now. At the time that the proposal was first floated, the CBO, in testimony and later as a publication, published something, a booklet, a monograph that was about 90 pages long of the questions that they intended to ask before they could model the Medicare prescription drug benefit. 90 pages of questions that needed to be asked. And I will also tell you, I worked on the ACA when it was passing the House in 2009 and again in 10. The first time it was passing in the House, I don't know if anybody remembers this level of detail for the history, but Ms. Pelosi, Speaker Pelosi, had to postpone consideration of the final vote by 3 days while CBO was doing 24-hour, pulling all-nighters, trying to answer some of these questions. And, you know, this is the biggest piece of legislation for a decade. It's the Speaker of the House who's calling, and they just said, sorry, we need more time. We have to keep doing this. We can't answer your question at this point until we've done some more modeling and data.
So, Karen, I'm sorry, just jump in. I can't help myself. It's wonderful to have Tim here, and then I'll shut up. But we focus so much on negatives and the breakdowns in the current system and so on. But over the last 30, 35 years, what do you see as some of the triumphs, some of the, where has the most progress been made in your view in terms of improving the public health?
Oh, in terms of improving public health, I'm sorry, I thought you were going to say in terms of budgeting. I'm saying,
No,
we're
not,
going
no,
steadily
in terms
downhill
of the impact,
in
in
budgeting
terms of,
right now.
Right. But improvements in the public health through policy.
Oh. I mean, the intuitive thing that I want to say right away is making childhood immunization universal. I mean, you don't get public health or health interventions of any sort, public or individual health, that bring back the return on investment that the polio vaccine does. I mean, most analytics of that make it look like you save $90 for every dollar you put in to the polio vaccine. It's incredible. But that's only for a relatively small swath. I think the thing that has probably been the biggest advance requires me to redefine public health for you, but I think that really is the gradual expansion of the Medicaid program so that it covers all pregnant women. Because when I first started working on Medicaid, there wasn't a floor for what pregnant women had to be covered at. And some states, I don't remember the numbers, forgive me, don't rely on this, but some states had women below, you couldn't get Medicaid coverage if you weren't below the level of 50% of the federal poverty line. And by the mid-90s, the Congress had gradually expanded it to be mandatory eligibility in all states, even the southern states, that you had to cover pregnant women up to 133% of poverty. And that huge expansion in prenatal care, like childhood immunization, brings a huge public benefit back. So I guess I'd say the gradual expansion of pregnant women and young children. Children are covered up to age 6 at 133 also.
Great. Thank you.
So before we open it up to the audience for questions, I had one more question.
Oh, sure.
And my question was really just with regard to single payer. Okay, so we're hearing a lot about this. It's renewed, right, at least for the moment. Thinking about the budget, can it be done?
Well, there are some strange things about trying to describe single payer in budget terms. Let's first talk about trying to describe single payer in general in political terms, which is half of America has private health insurance right now, and they get it through their employers. And we went through an episode, you were in Washington at the time during the Clinton administration, when people's fear that they were going to lose their employer-sponsored health insurance was so big that they were opposed to expanding it for anybody else. You know, the Harry and Louise period there, that people were just afraid. So moving to single payer politically has that huge weight of getting past the fear that you're going to lose everything, that the people who have insurance are going to lose the insurance. But for budget purposes, it's particularly difficult because all of a sudden, all of these expenses that don't show up in the federal budget of Brooklyn Law School paying, I don't know who you insure, but Brooklyn Law School paying Blue Cross benefits, that's a totally private transaction. You create single payer and suddenly that becomes a revenue from the federal government that we need taxes to pay for it, and then it'll be federal spending. And immediately at that point, you have created what some people describe as the largest tax increase in history, because you've taken the exact same expenses that are now a totally private transaction. And even if people continue to get the exact same health insurance, and Blue Cross is the contractor, as it is in some places in Medicare, and so it's still exactly the same administered program, but for budget purposes, it could become, at that moment, taxes and spending. And imagine in this current political atmosphere if I told you, let's double the tax base and let's double the federal spending. So just as a budget item, that first level of, if you will, taxonomy, of description of what is this, I think it makes the political fight even worse. It's not just people who are afraid they're going to lose what they got, but suddenly politicians are saying they're going to double your taxes and double the size of the budget. So, you know, it's just that little tiny thing. I myself think that that kind of huge sweep would require a whole lot of political support. And I still keep going back to the one that was being debated and considered during the ACA, which was the public option, where people could choose to be in a public program without abolishing everybody's private health insurance at the same time, so that people who have employer-sponsored health insurance can be confident they're going to keep it. And those people who want to move into a Medicare-like public plan can choose to do so, and you can describe it at that point as choice rather than creative destruction or whatever Mr. Sanders is calling it at this point.
Oh, very good. So questions from the audience?
Yes, thank you, Professor. I was wondering if you could speak a little bit more about, I know we know about the role of the Congressional Budget Office during repeal and replace. It was mostly along the lines of X number of people would lose their coverage, but it seemed like you mentioned one of the constraints of the Affordable Care Act and moving down the Medicaid rate was to make it within the confines of the budget. So I feel that during repeal and replace, a lot of legislation was going forward without kind of the final determination of the Congressional Budget Office. It was almost like whatever they said, you know, forget it, whatever. Is that mostly because the proposed replacement would not cost more money, or just kind of what were the confines of the CBO for this process?
Well, there's a budget answer to that, and then there's a political answer. The budget answer is all of the proposals were cutting. There wasn't a question of whether they needed to raise new revenues to be able to hit pay-go in this. They were slashing the hell out of the Medicaid program, and that, quote, quote, saved money for the federal budget, so they didn't have to offset it. They didn't have to look for new other cuts. They had a lot of cuts already built in by slashing Medicaid. And that's the budget kind of thing of they didn't need to wait for the numbers. But the more fundamental thing that you touch on there is a lot of the Republican members, the views I express are my own, a lot of the Republican members didn't want those numbers out before they voted. And a stampede is a stampede. You can change the rules of the House or the Senate or avoid them altogether if they're determined enough. And so, when you heard at the very last minute Mr. McCain calling for the return to regular order and wanting to carry out hearings and committee deliberation and debate and those kinds of things, one of the things that he was talking about also was we need to wait till the CBO tells us what they think is going to happen if we do this. But a lot of people, knowing that they were slashing the hell out of the programs, didn't want to wait to see how many people were going to lose their health insurance at the same time. Was that responsive?
Yes.
Yeah. So as a budget matter, they didn't need to wait for it because it was going to meet PAYGO. There's no question because they were cutting the program. Now, what we can be looking for is what happens with the tax package that's coming up, where they are going to, if they're going to live with PAYGO at all, they're going to have to get a score and estimate how bad they're hurting the deficit with that. But there may be a stampede for that one too. Yes, ma'am.
Professor Taylor.
So I'm trying to recall something that happened, I think, during the Affordable Care Act, where there was a scoring by the CBO, and then I think there was a time when it was rescored, and then you end up with different figures, and then everybody fought about that, and the question became whether or not there is a lack of integrity or a lack of reliance, a reasonable reliance on what the CBO comes up with. Can you talk a little bit more about what happened during that process?
My memory is fading on this. You're right that there was a rescoring of this when CBO said, we've got more data, we've got better thoughts on this. But you prompt me, if you'll let me, to talk about something a little more abstract than that, which is, I should have said this during the basics. Nobody, not even the CBO and certainly not the Budget Committee, thinks that the number they come up with is the right number. When people say CBO, critics say CBO gets the numbers wrong, you're missing the point at that point. Nobody thinks that the number is right. I've tried to say is that the CBO score is, and I'm really bad with sports metaphors, so somebody help me if I screw this up, but in tennis matches, the people who decide whether the ball goes in or out, are they line judges? I think the CBO is the line judge in this instance. And you don't go back and say, ooh, were they right? Let's stop, bring out the measuring tape, let's go back and look at the film and things like that. No, the line judge says, it was in, it was out, keep playing. The game goes on in that circumstance. And well, as I recall, they rescored because they got they got different data themselves, and so they think that their job is to give the most accurate they can, recognizing that what their job is to say is to come up with this 1-point estimate. Because if they don't, then what it dissolves into is a bunch of politicians who really don't know anything about modeling like this, each having his or her own score, and at that point you've given up on the budget process because everybody will make up their own score to go with. So the Budget Act of '74 and the stuff that has come since then, I think is a determination of we're going to have an umpire or a line judge or whatever official you want to call it, who says this is the number, now let's debate, rather than having everybody debate what the number is, if that makes any sense. But
yes, it does.
I'll go back and I'll find out why they decided to rescore. I think it was that they came up with some new data, and it wasn't political. I do not believe that it was a political decision from the CBO.
And my other question goes to politicizing the CBO, because I guess I am more skeptical than you are in terms of whether or not that office could be captured. I understand your point that the CBO doesn't want to be lobbied and tries to stay away from politics, but Washington is politics. So
No.
I guess at some point, I guess I would be a little bit more concerned than you are about that.
I don't mean to sound unconcerned about it. I actually have and I have a short piece on in another area about an area that I'm really concerned about CBO stuff, but about it being captured. But the director of CBO is appointed for, I used to know this, 10 years, I think. So he or she outlasts whatever the majority may be in the current House or the current Senate. The politicians will have changed during that time. So they're not directly reporting to any one person to make him or her happy. And I don't know if you noticed, but already former Secretary Price, under the Trump administration, used to be chair of the House Budget Committee before he went into the administration. And he was, if not the nominator, at least one of the biggest champions of the current head of the CBO, who was definitely a Republican when he came in, the head of the CBO. And then when the CBO started cranking out the numbers saying repeal and replace is going to cause this many million people to lose their health insurance, suddenly Dr. Price was saying, this guy is in the pocket of the Democrats. And you're just looking and saying, you nominated him. This can't possibly be true. So I think
That's a good example.
by making everybody angry at one time or another, and believe me, Speaker Pelosi was pretty angry when she had to postpone the vote by 3 days, too. By making everybody angry, it just makes me think that they're not at least completely captured by this. And if you, as your dean has just said, or as you were saying, it is Washington, but if you think that you can get to it completely uncaptured, I point you towards the Supreme Court and say, do you think they're completely uncaptured by politics? I don't think so. So my concern about CBO capture is not so much that I think anybody is corrupt or anybody is actually trying to lean Republican or Democrat, but that they are so dependent on existing data sets, they don't have the time or the money to create their own data, that to the extent that data sets that they use are produced by private sources. So let me just make it up in a field I don't know much about, air pollution and the chemical industry. If the chemical industry is producing all the data sets on economics of air pollution, that may be the only thing that CBO has to turn to at that point. And I'll make it up again, the Sierra Club probably isn't producing data sets that are good enough for CBO to rely on. That's not the same thing as capture, but it is a skewed marketplace in some fashion. And I fear, for instance, that in pharmaceuticals, we have a little bit of that going on at the CBO.
So a student.
I was late, so I apologize if you covered this. If you did, you could just move on, and I'll come ask you after. But does the Congressional Budget Office play the same role for agencies?
No.
In the
And we didn't
process?
talk about that, so you don't have to worry.
Oh, good.
No, the process that I'm describing here is how legislation is enacted, not how it's ultimately implemented. There is another budget-making agency in the executive branch, the Office of Management and Budget, OMB. But what I want to emphasize is that under any administration, Obama or Bush, I don't know what's going on in Trump, I just don't understand. But Obama or Bush, the OMB is a political organization. It is not nonpartisan. It's part of the executive office of the president, and its goal is to advance the president's agenda. So if the president wants there to be a capital gains tax cut, the OMB will find a way of scoring things so that it looks like that works. If the president is in favor of universal health insurance, then the OMB will look at it. And CBO and OMB don't come up with the same scores about moving legislation. Now, inside the executive branch agencies, say if, well, let's just make up an easy one right now, a painful one. But if Mr. Trump says there's not going to be any guidance and navigation for people to figure out how to get health insurance, and he just cuts off all those executive branch efforts, then a CBO, if the Congress were doing that, would model, okay, now how many people are going to lose health insurance because of this, and how much money is that going to cost or lose in one way? The OMB doesn't do that internally if it's against the interest of the president to model those kinds of things. And it's also not nearly as transparent as the CBO is. So.
Professor Porter, I have two questions you can answer very briefly. The first question is terribly, outrageously unfair, and the second question is outrageously selfish. So the first question is, and I mean this sincerely.
Which is coming first, the unfair one? Or the
Well, you'll
selfish?
figure it out. Here's the unfair one. You are, I mean this sincerely, I believe there is no one in the country that is more knowledgeable about healthcare, Congress, and the entire process. So what is going to happen with ACA repeal and reform over the next 12 months? What is your prediction?
Okay, the views I express are my own, and what time is it now? It's Thursday at 7, and I haven't looked at Twitter since last night at 7. So I have no idea. And yesterday I was teaching a public policy class, and someone came in and said, by the way, Paul Ryan just tweeted his answer to Don. I was, what? It's impossible. So with the timestamp on it and the disclaimer, I believe that the current floated compromise from Mr. Alexander and Ms. Murray to pay cost-sharing reductions and to sort of reestablish the solvency of or the viability of the insurance markets will in some fashion pass, and that the lines that Mr. Trump and some of the other Republicans have used of, I don't want to be behind a bailout of insurance companies, can be answered if the insurance companies that raised their premiums because of how much chaos the Trump administration inserted into this, if they raise their premiums, that they can actually do rebates to individual consumers, and that states can require them to do that. We have a model for that in the medical loss ratio stuff that's in the law already. So if states require rebates, that would solve the talking point that Mr. Trump and others have had. So I believe that they will pass it because it's just too sudden. We can't have the insurance markets collapse. I believe it will pass at a last-minute deal having to do, you remember when I said that without discretionary spending, the program just doesn't have any money? We're running out of all money on December 5th in discretionary spending, so they got to do something or they're going to shut down the government. We're also about to hit the debt ceiling. We didn't talk about the debt ceiling, but it's another gun to the head. So we're going to run out of cash or shut down the government. We're going to run out of the debt ceiling we're going to hit the debt ceiling on December 5th. And we're about to collapse insurance markets in this country, and I believe it'll be one big macro deal where everybody says, I got screwed and they won, but I'm voting for it anyway, and that we will salvage the insurance markets for a year and a half longer.
So something will happen in the way you described.
Something that'll keep the insurance markets viable, yeah.
Okay.
I do believe so.
So here's the selfish question. I'm sitting here having an out-of-body experience. I'm thinking of how grateful I am to be at a law school with Professor Karen Porter, running our health science and public policy center and organizing for our students, our faculty, and our community, people who attend our programs that is of this caliber. I'm thinking of how fortunate I am, I mean this just sincerely, to have been in a class in law school where I've got people like you and Sonia Sotomayor and Peter Kugasian and Martha Bashford at the district attorney's office, about 15 or 20 law deans, and I just think this is incredible. And then I'm also thinking of our students here who I know, because I know you all so well, you should be thinking which among your colleagues that you're going to be so proud of that you get to be, or they're going to be proud of you. I mean, who's going to be the Professor Westmorelands or the Sonia Sotomayors, going forward. And so you've had an incredible career. Would you encourage people, our students who are here, to pursue that kind of path in public service, in public health? And how do you get started?
Yes, I would. And I would encourage people to pursue it while they're relatively young. These are hard jobs with long hours and bad pay. And once you have dependents and once you get a little tired, it's harder to do those jobs.
Well, that's why you're not in pharmaceutical sales. You know?
Yeah,
I mean,
it
really.
is.
There's
But having said that, they're also the most gratifying, they're the jobs where young people can make more difference than any place else. You go to, forgive me if they're corporate law firm people here, present company included. If you're a young associate in a corporate law firm, the stuff that you do influences what the senior associate does, influences what the partner does. You know, if you're a young person on Capitol Hill in a committee staff job, somebody's going to turn to you and say, is it a good idea to immunize children with federal funds or not? And then you're the person who's making the decision at that point. So I can't think of a place, except in public service, where you can have that much influence that at the end of the day you can come home and say, I did something worthwhile today. So you need to do it while you're young because they're just hard and bad pay. But at the same time, it's the right time to do it when you're young because no other young person's job is going to give you that much gratification and feel like you made a difference. Does that answer your question?
It certainly does. Thank you very, very much.
So please join me in thanking Professor Timothy Westmoreland